This Beyond Clean Articles on the Go feature is titled, Let's Stop Kidding Ourselves. What's the problem with tracking sterile processing productivity? Written by Hank Balch, founder and president of Beyond Clean. How many of your facility administrators really know what your sterile processing team does? Or, perhaps a better question, how many of them know how long it takes for your team to do what they do? How long should it take? Is there even a good answer to that question? First, let's start with some bad answers to these sterile processing productivity questions. Load sterilized. 2 of my current SPD departments are operating under a productivity metric of loads sterilized per pay period. This is a measure based solely upon how many times your team turns on their sterilizers, high and low temp. As our former process improvement analyst Michael Walker once explained, it would be like judging how busy a restaurant is by how many times they turn on their oven. Whether it's a load of 1 small peel pack or a maxed out load of ortho loaners, it all counts the same. The real difference, of course, could be 5 minutes of true labor on 1 peel pack versus 3 hours of true labor for 10 consignment trays. Surgical case volume. Another common productivity metric for SPDs is pulled from OR surgical case volume data. For many facilities, as with the load sterilized model, surgical case volume only has a remote correlation to sterile processing's workload. 3 Da Vinci cases on a schedule can triple or quadruple the labor hours needed for production compared to a simple cataract tray. But most generic surgical volume metrics do not make any adjustments for acuity levels or case complexity. So facilities with simpler procedures and/or surgical trays have a much greater advantage under this measure than their more complex peers. Instrument sets processed. A third common productivity measure for SPD departments is instrument sets processed. In one sense, this is a much more logical measurement of the presence of work in our department. Larger numbers of instrument sets to process does mean more labor hours would be necessary to complete the workload. This metric would also capture a little more of the complexity of the surgeries being done in the OR, since the number of instrument sets is often an indicator of greater surgical complexity. What this measurement does not account for is the variation of internal complexity between instrument sets. Under this model, a 5-instrument set is measured the same as a 125-instrument set, a possible difference of 15 to 20 minutes of labor hours. Productivity ex opere operato. Worked in the working. Although the productivity measurements discussed above are the 3 most common metrics used in the CS SPD department, they still don't scratch the surface of the variation found in different hospital settings. Some of our departments also service the ER, respiratory therapy, and the cath lab. Others only serve the OR. Some teams are responsible for cleaning patient care equipment, such as IV poles and pumps. Other facilities have third-party contracts with folks like Hillrom to take that off our plate. Some SPDs pull all surgical instrumentation and disposable supplies for next-day cases. Others only pull instrumentation, and still others aren't responsible for pulling anything, with an OR team who set up their own procedure carts. My point in all this is not to say, there's no hope, let's just throw in the towel and give up on setting productivity standards altogether. Many productivity programs like Premier and Action OI do attempt to find helpful comparison groups based on department surveys so that you have standards set that are similar across comparative departments. Articles like the recent write-up in Amy's BIT journal by Donna Swenson and Eddie Conklin offer other good ideas for how to create your own productivity metrics. But where should we really begin? I say it has to start with true pay for performance for SPD team members, true incentives for frontline and upline leadership who excel at what they do, true returns for meeting and exceeding whatever measure of productivity and/or quality your facility adopts. Finding better measurements of our current state of productivity is great. Tweaking that for future benchmark standards is expected. But as long as the only use or application for sterile processing productivity metrics is in an administrative position review committee for approving or denying additional positions, we're missing the mark. Let's push this industry forward. Let's commit to finding creative ways to make productivity and quality pay. Our teams and our patients deserve it.